The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, thank you for joining us today. The webinar will begin at the top of the hour in 2 minutes. Again, we will begin in 2 minutes, and thanks for joining. Hello everyone, thank you for joining us. The webinar will begin at the top of the hour in just a few moments. Again, we'll begin in just a few moments. Thank you. Good day and welcome to this Health Catalyst webinar. As a quick introduction, Health Catalyst is a next-generation data, analytics software, and decision support company committed to being a catalyst for massive, sustained healthcare improvements. My name is Sarah Stokes, and I will be your moderator today. Now let us begin with today's webinar, Healthcare Analytics, Right Brain Advice in a Left Brain World, presented by Dale Sanders, Chief Technology Officer here at Health Catalyst. Dale has been one of the most influential leaders in healthcare analytics and data warehousing since his earliest days in the industry, starting at Intermountain Healthcare, where he was the chief architect for the enterprise data warehouse and regional director of medical informatics at LDS Hospital. This webinar was originally advertised with a 30-minute runtime, but Dale ended up developing enough great content that he plans to fill a full hour. So we have expanded this webinar. If you are unable to stay on the line for the full webinar, fear not, we are recording today's session and you will have access to it. We urge you to submit questions throughout today's presentation via the questions pane in your GoToWebinar control panel, as Dale will answer questions at the conclusion of the presentation in a Q&A session. As I mentioned, we are recording today's webinar, and by midday tomorrow, you will receive an email with links to that recording, the presentation slides, and a transcript. If you'd like to stay in the loop on upcoming webinars and all things Health Catalyst, you can follow us on social media. Our handle is @HealthCatalyst. I will now turn the time over to Dale. Dale?
Thank you, Sarah. Appreciate it. You know, as I was reading this title and this abstract, I was going, you know, this is going to be interesting. I wonder who's giving this. And then I thought, oh, it's me, and I better live up to the billing here. So hopefully, everyone, I hope it lives up to the abstract and the title. That's definitely my sincere attempt. We'll see how that goes. So let's dive in here. So ironically, I'm going to start a right brain discussion with a very left brain assertion, a bunch of if, and then statements. But here's the assertion today, though, friends, that if healthcare analytics is fundamentally about decision support and changing or maintaining human behavior based on those decisions, and healthcare data quality other than imaging is overall very poor, given the criticality of the mission and the complexity of decision making, that is, there's a gap between the data we do have and the data we should have to support the criticality of healthcare. And changing human behavior with poor data is incredibly difficult, if not worse than difficult. Poor data, if presented as good, entrenches the wrong behavior. And we'll talk more about that later. Then, my final assertion is that healthcare analytics success must be accompanied by an inordinately heavy emphasis on human engagement to overcome these shortcomings in data. So that's the fundamental assertion of today's discussion. Here's the agenda. We'll talk about the state of healthcare data and analytics, kind of stating my case that our data is pretty poor. I'll go over an academic reading list for the human side of analytics, talking about all the factors that affect human behavior and decision making and that sort of thing. And then I'll share the non-academic side of things, which is lessons learned from my career in the field, in the Air Force and space and defense sectors at Intermountain, Northwestern, Cayman Islands, and more recently, the last few years at Health Catalyst. So let's talk about healthcare data and analytics in a brief state of affairs. I came across this paper that I wrote almost by accident. I'd forgotten about it. And we published it in 2002 in what was then the Journal for Healthcare Information Management. That journal no longer exists, actually. But the title of the paper was Healthcare Analytics Standing on the Brink of a Revolution. This was coming to the end of my tenure at Health Catalyst. At Intermountain. I left Intermountain in 2005. And if you read the article, I have some pretty lofty aspirations about what analytics was about to do. And there's a highlighted quote there in the middle of the page on the right that says, process improvement and behavioral change are ingrained in every aspect of an analytic culture from the CEO down. In a reporting environment, these issues are less visible and more often than not an afterthought. So what I was trying to say there, that there's reporting and then there's analytics. And analytics is really about behavioral change based around data and insights. But I have to say, in 2019, 17 years later, we are still not on the brink of the revolution that I thought we would be. And so we've got to figure out why, friends, for the sake of all of us and our families, patients, and families that depend on better healthcare. We've got to accelerate this. And hopefully that's what I'm going to help with here today. We'll talk a little bit about the technology, almost nothing. What I really want to talk about is the behavioral and human side of this while we build out better technology and the digitization of the patient. So there's a cartoon that I drew in one form or another back in my Northwestern days. And it amounted to our strategic data acquisition roadmap. So if you look at the patient at the center of this, if we're going to truly understand that patient, we have to round out all of the data content represented in those bubbles around the cartoon. For the most part, we're stuck in the lower left quadrant in healthcare encounter data and claims data. We're making a little bit of progress in biometrics, patient-reported outcomes, playing around with consumer data, socioeconomics, genomics, epigenetics, and microbiome are just barely getting off the ground. But we have a long way to go, friends. So what I'm suggesting here is that we can't rest on our laurels, that we have to keep pursuing the strategic acquisition of data about patients in order to better provide both population health as well as precision medicine. I'm not sure that this graph adequately captures what I'm trying to communicate here, but in essence, it is the quality of healthcare data relative to the ease of human behavioral change. And my assertion here is that with poor data quality, affecting human behavioral change is extremely difficult. At some point, you probably hit an asymptote around human behavioral change. It doesn't matter how good the data quality is. But I think most of us would argue that where we are now with data versus where we should be, given what we're trying to do with the mission, is too big a gap. So as data and analytics and informatics professionals, we have to campaign to raise our performance on that axis. So this is what I'd like to do. I'd like to kick off a $175 billion 10-year mission to digitize the patient. Tongue-in-cheek, not the billing process, which is what we've done so far. And to me, this feels like our generation's moonshot, is digitizing the patient. Frankly, I'm less interested in going back to the moon and Mars, oddly, given my Air Force background, than I am about better understanding humanity and the earth that we belong to. People like John Rogers at the Center for Biointegrated Electronics at Northwestern are the early pioneers. They are the Wright brothers of digitization of the patient. And those are the folks that we need to support, fund, and collaborate with to push a greater understanding of the patient at the center of the data ecosystem. There's a very good article published by IEEE about the creation of digital twins that came out in 2017, I believe. Short read, worth reading. So if I were the benevolent dictator in charge of all decisions like this would certainly be my generation's aspiration. And by the way, that 175 billion is relative adjustment to the Apollo budget. I think the Apollo budget was somewhere around 25 billion. And so this is similar kind of numbers, 10 years, that kind of investment, that kind of commitment to a better understanding of humanity. And if you really peel this back, what we're trying to do is optimize the potential of humanity. I worry that if we don't optimize healthcare, and if we don't optimize human health in the three axes of mental, physical, spiritual, that we won't live up to our potential and possibilities as a species. So this is bigger than just healthcare. This is about the potential that we have given our existence on this wonderful planet. If I were still a practicing C-level in the trenches of healthcare analytics, this is the kind of conversation that I would have with my physicians. I'd say, look, here's the truth. We know that all of these quality measures are a giant pain in the neck. We know they are burning you out and stripping you of your sense of mission, autonomy, and purpose. We also know that most of these measures are clinically irrelevant. It's a spiral of frustration. You are forced to collect irrelevant data. Then we measure your performance according to that irrelevant data. Going forward, we will minimize all of that burden, including the pressure we put on you, and we commit to giving you the data you want, when you want it, and how you want it, so that you can practice the top of your profession. I think quite often we are reluctant to acknowledge what physicians know instinctively, that the data that a lot of us process and interact with is a poor version of the truth and not really what physicians need to provide the best care possible. Going with the softer side of data and acknowledging these kinds of issues, being transparent about these kind of issues and truthful, goes a long way towards building a collaborative environment and also acknowledging that it's okay that physicians be burned out and thereby relieving some of the pressure on them. The state of healthcare data, I would argue that significant amounts of it is qualitative, not quantitative. And I'll go into quantitative data here shortly. But some of the examples of quantitative data that we have are lab results, some of the measurements that we see in diagnostic imaging, vital signs, dosing, genomics, anything that you can assign a discrete number to, a number, not a diagnosis code and not clinical notes. Those are qualitative data sources. Clinical notes are, they need some work, frankly, right? There's lots of studies that indicate that our clinical notes are a reflection of billing and malpractice motives, not about patient care and handoff. But they do represent the potential to be a very valuable source of data, but it's not quantitative, it's qualitative, it's analog. We tend to describe diagnosis codes and ICDs as being discrete data, as if discrete data is quantitative, but that is not the same thing. Discrete data is not necessarily quantitative data. Quantitative data is the world of numbers and math. And speaking of that and acknowledging our shortcomings, I think it's important for us as an industry and as a professional body of science to acknowledge that our mathematical models in healthcare are inadequate given the importance of our mission. Now, is that the fault of healthcare or is that the fault of the mathematicians? Probably a little bit of both. The maturity of any body of science and engineering is directly proportional to the mathematic models which describe that body's predictability and reproducibility. That's my assertion. Inspired by the writings of Thomas Kuhn, by the way, a well-known philosopher and scientist. Observation, measurement, and data collection precede the development of mathematical models. It's Newton sitting under the tree with the apple falling on his head that helps him observe and start to think and model gravity. We must acknowledge the overall lack of data and maturity of mathematical models in healthcare and adjust our approach to decision-making according to the reality of our current state. So I'm not saying that we should dismiss the data that we have. We just have to adjust the way we interact with data, the way we communicate uncertainty to one another, the way we communicate uncertainty to patients within the acknowledged shortcomings of the data and models that we have. This is my depiction of that progression. Many of you have probably seen this before in other lectures and webinars. From left to right, this is how I see the progression of mathematical models as it relates to the predictability and the reproducibility of a body of science, with Newtonian physics being on the far right, jokingly Facebook ad feeds being on the far left. The math associated with human psychology and economics is pretty abysmal in terms of predictability and reproducibility. And we are just barely ahead of that, and yet still slightly behind biology, because if you really think about healthcare, it's the combination of biology and psychology for the most part. Human behavior and the biology of the human body coming together is what constitutes healthcare. So on an individual sort of cellular, genetic layer, biochemistry layer, we understand the human body reasonably well. What we don't understand is how that relates to health and how human behavior affects that biology. And I would say, if not for randomized clinical trials, which have problems of their own with predictability and reproducibility, our mathematical maturity would score even lower. So simply acknowledging that as an industry and saying, okay, what are we going to do? How are we going to inspire mathematicians, physicists, and others to participate in the modeling of healthcare so that we move to the right on this diagram? In order to build those models, we have to collect more data, is my fundamental assertion. Going back to physics, electrical, computer, aeronautical, aerospace engineering, that's all about collecting data, then building models to describe what you've observed in that data. So data is fundamental to moving to the right here. Now, we get credit from randomized clinical trials, but if you want to read a really well-written book by a very capable investigative journalist from NPR, Richard Harris, this is a sobering assessment of published research. Talks about the inequality of mouse models as they relate to human models, a field that I knew very little about, which was cell misidentity and contamination. I had no clue about that. There's a couple of chapters on it. I think we've all heard about the debate and the danger of p-values. And then, of course, the culture of research that tends to inhibit open data sharing to allow scrutiny and reproducibility. So reading this book was motivating to me about how important it is that we move aggressively towards the digitization of the patient as a country, and also start adapting and changing our human behavior relative to the data we collect. This is a metaphor that I use to describe the situation that we're in. This is my family on the left at Yellowstone last fall. That's a real picture of my analog life. But I would argue that this is healthcare's digital view of my life. It's a highly pixelated image. On top of this poor data, we have the unusual complexities of human behavior. Tribalism like I've never seen in my life in today's society. The social norms of the tribe being an enormous influence on behavior. There's the truth according to data. There's the truth according to perception, and going back to tribalism and the whole debate about fake news. There's Homo economicus in evolutionary biology, that is what amounts to modern day survival of the fittest. How do we express our genetic propagation in today's world when physical survival is not quite what it was to Neanderthals? It's more now about the economics that drive our behavior as a proxy for genetic propagation. And then, of course, there's the behavioral economic side of this, which is the irrational side of Homo economicus. So the economy and our economic stature and environment affects our behavior. Our tribalism affects our behavior. It also affects our truth or our perception of the truth. And it turns out that social norms of the tribe tend to be the most dominant influence on our behavior. And so with analytics, if you go charging headlong into a violation of the tribe and the social norms of that tribe, you're going to elicit an immune response from the participants. They're going to reject your analytics. They're going to refute your analytics. They're going to layer their perception of the truth on your data, and you're going to stall with progression. I credit a friend at Northwestern, a psychiatrist, researcher at Northwestern, that first enlightened me to this issue of tribalism, all the way down to sense of belonging to teams and professional groups. And I've thought about this in my sense. I almost have no tribal affiliation. The closest thing I have to a tribal affiliation is my Air Force identity, and that's pretty distant. So I've been a bit clueless to tribal identity until I would say the last 10 or 15 years. And I wish I would have known more about my violations with analytics of people's sense of belonging to their tribe. It's critically important. So when you engage with analytics with an individual, you need to understand their personal identity and the social norms of the tribe or tribes that they belong to. It's really important. And then work with them within that context, and realizing that if you step on the identities of that tribe, you're likely not going to progress with your mission and your dreams and hopes of analytics. Okay, so let's talk about our reading list here, our decision making, human behavior, all of those things. I had an undergrad student in a lecture ask me a few years ago, what's the most valuable class you've ever taken? And I was pleased to realize I didn't have to give it a second thought. And it was an epistemology philosophy class called What is Truth, taught by Dr. Paul Pixler at tiny little Fort Lewis College in Durango, Colorado. That book and that class and Dr. Pixler taught me how to think. It taught me how to peel away the false layers of belief until reaching fundamental truths. But I also said it confused the hell out of me, and I've never been quite sure of anything since. The book is no longer in print, which is unfortunate. But if you can find a copy, it's a great distillation of great philosophers talking about the pursuit and the understanding of truth and people's various perceptions of that, and how we as day-to-day human beings can apply that when we interact with people and when we think we've found the truth of our situations. But it has fundamentally affected the way that I address problems and the way that I think it created a greater sense of empathy in me towards the various flavors of truth and the human perception of that. This is another favorite book of mine, maybe my favorite sort of business-related book in the modern era that I've ever read. A lot of you hear me talk about it all the time. Daniel Pink's book about what motivates human behavior. It's a modern take on Maslow's hierarchy, a little simpler for me to grasp. And that is every human being strives for mastery of a skill that they can feel good and proud of. For the most part, they want to be left alone. They don't want to be micromanaged. But if they have a need for help, they want to feel like they can ask for it. But for the most part, they want to be left alone. But they do want to feel a sense of purpose and belonging to a mission that's larger than who they are. And so when we as data and analytics professionals engage with clinicians, we have to ask ourselves, what are we doing with our data, with our skills, to enable greater mastery, autonomy, and purpose for our clinicians, patients, and administrative leadership? And I would argue that in the US, our national analytics strategy is detracting from these basic human needs, if not demoralizing them altogether. And it's time for us to change. A couple of more books. Now, these are kind of an interesting mix. Will Durant is one of the best writers, in my opinion, of all time. There's no book that I wouldn't recommend if Will Durant was the author. This is a great, fascinating look back on history. And my interpretation of this book is that history doesn't repeat itself, but human nature does, which then leads to repeated history. And so if you understand these patterns of human behavior that have repeated themselves for thousands of years, I believe it helps us understand the patterns that we see in human behavior today, and it helps us anticipate the patterns that we're going to see so that we can get our thinking ahead of that rather than reacting to it. We're thinking ahead of the human patterns that we will see in our analytics and data strategies in healthcare. One of the great quotes here is that, therefore, the laws of biology are the fundamental lessons of history. We're subject to the processes and trials of evolution, to the struggle for existence and the survival of the fittest. And that really boils down to our analytics strategy as well. When you're interacting with clinicians and things, in addition to mastery, autonomy, purpose, you have to ask yourself at a very biological level, what are we doing that might make this human at the other side of the discussion feel better about their future and their struggle for survival at a very biological level? I had a great piece of advice one time from a mentor of mine at TRW who said, never threaten another person's livelihood. And that was mostly in the job arena. But what he was saying is that if you threaten someone's livelihood in their job, you're essentially threatening their sense of survival in the biological sense. And if you ever hope to change anyone, if you ever hope to interact collaboratively with anyone, you cannot threaten their sense of livelihood and survival. The next book here is a quiet book that very few people know about. And I would have endorsed it whether it was the 50th anniversary of Apollo 11 or not. George Miller was the quiet, unsung hero who led NASA's human spaceflight program. Nobody really knows about him. He came along after lots of problems and failures, early failures in the program in 1963, took over, and he's the person who organized the human spaceflight program to success. And he did it in 6 years. A lot of people think that we did it, at the end of the decade as if we had 10 years. The reality is George Miller did it in 6 years. It's unbelievable. So if you want to read a book that describes incredibly complex organizational challenges times unprecedented engineering challenges times political challenges times human lives at stake times hopes of the world on your shoulders. And he lived to be 97 years old. I can't imagine anybody living through the stress of something like that. He lived to be 97 years old. One of the reasons I adore this man is because he was also a TRW employee, and I worked for TRW long after he established himself. But he was a lingering presence in the TRW culture. So we all had a sense of worship for George. He was brilliant but humble, capable at the high levels of thinking, strategy level, but also at the lowest levels of electrical engineering. There were 410,000 employees and contractors involved, 20,000 companies. And in those days, we didn't have webinars and WebEx. He had to patch together things like conferencing systems to keep up to date on the Apollo program and the manned spaceflight program. I included a copy of his org chart, by the way, just for the sake of reference. So I have to say, when and I don't hear it much anymore, thankfully, but when healthcare leadership talks about their moonshot, they're not even close. And they are actually, I think, denigrating the significance of the accomplishments of those associated with that achievement. But what we do need to do is take on a similar level of commitment if we are really committed to the full potential of the human species. This is our moonshot. This is what we have to do in healthcare, is think bigger and higher than we ever have before. One of the single best references for the art of decision making, the human side of decision making, is in this Harvard Business Review article when HBR was a little bit better than they are now. Frankly, they're not as good at content as they used to be. This is from, it's a tattered, dog-eared version. I think this is from 2015. I've carried it around forever thinking that it had long since gone out of print. But I was surprised to find that you can buy it on Amazon. So of all the books that I'm suggesting for reading today, this is at the top of the list, probably the top 3 references. It's the most condensed and succinct about the human side of decision making and making sure you don't get trapped in all the biases that we're subject to being trapped within. I think I'm almost done with the book recommendations here. If you haven't read Nudge, it's a great, relatively easy read from a Nobel laureate. In summary, it would say, and I'm simply, grossly oversimplifying here, but give people freedom of choice, right? Back to autonomy, according to Daniel Pink. Give freedom of choice, but nudge, don't shove with data towards the preferred behavior. I'll talk a little bit more about that in my lessons learned in my career. The book in the middle on human nature is a self-help book. I'm usually kind of cynical about self-help books. But this is one that I recommend reading. And it was recommended to me by a friend whose judgment I trust. And as I was reading it, I kept thinking, wow, this person, by the way, the author, Ed Wilson, doesn't have a cognitive science background. I think he's just an author and a historian, essentially. But he weaves really interesting stories of history and human behavior, similar to what Will Durant did in his book. But he ties it back to self-improvement and what you can learn from those patterns of human behavior over the centuries. And as I was reading it, I thought, wow, yeah, this person is describing my shortcomings and flaws. And then I also realized that it was helping me understand other people and how to interact with others. By the way, I am by far the least perfect person when it comes to interacting with other folks. I can be blunt. I can jump to conclusions. So I have all sorts of flaws here, friends. I don't want anyone to come across believing that I believe in myself here. I can be like a bull in a china closet when it comes to change and things. But I keep trying to improve, and that's what these books are all about. Last book on this page from Tali Sharot, brilliant cognitive scientist. I believe she's at the University of London. She'll be speaking at our Health Analytics Summit this year, by the way. I was really excited that she agreed to speak. She comes at the human side of data-driven behavioral change from a scientific perspective that I think is better than any other book I've read. Highly recommend this book. And it kind of confirms common sense, and that is data is persuasive when it fits your worldview, right? If you present data to someone today, if it supports their view, wow, they're all over it. If you present data insensitively, how do I say that? Can anybody help? In other words, if you violate a person's sense of tribalism and survival with the data that you present, guess what? It's going to entrench the opinion that you're hoping to change. And boy, do I see evidence of that like I've never seen in my life in today's society. If any of my Facebook friends are listening today, we had quite the spirited debate about the recent tweets from President Trump towards the 4 members of the squad in Congress. It was quite an interesting debate to see both sides of that opinion emerge. And there's no budging opinions with data in that context. So my advice to everyone is give up. Stop convincing and start connecting. Okay, another great reference here that has had a profound impact on my career and life. And this is one that I actively, day to day, think about and practice. The Rand Corporation wrote this paper, I think it was in the mid-'80s. It's about the time I was exposed to it. This is actually my flavor of that paper, so it's not exactly the same, but it was inspired by the Rand Corporation. And what they essentially said is that if you're going to be an effective change negotiator, they were actually talking more about treaties at that time. There are 3 qualities that you have to exude to the persons and people on the other side of the negotiating table. That is, you have to be believable, relatable, and credible. You have to be honest, sincere, trustworthy, and if the people don't know you well enough to know that, they have to see evidence of that in your background. Believability is fundamental. You cannot compromise on that. Relatability is the question, is this person similar to me? Can this person empathize directly with my situation or role? This is where tribal affiliation starts to take place. All right, can you affiliate with the sense of identity and tribes that I belong to, whatever they might be? You have to find common ground for relatability to be an effective change negotiator with analytics. It doesn't matter if it comes down to shared sports teams, maybe the same hobbies, but at some human level, you have to find the ability to relate to the other person in order to have an effective relationship from an analytics and data perspective. And then the last criteria is the credibility factor. And that is, even though there's a large overlap in the Venn diagram in relatability, hopefully there's a large relatability overlap, there has to be something about you that's different enough and respected enough by the person on the other side of the table that they appreciate you and they welcome your dialogue, they welcome your expertise, they welcome your involvement in their lives. So this is something that I would say we're not great at this in health catalyst culture, but I would say there are elements of this in our health catalyst culture, and I'm probably the biggest flag bearer. But being very deliberate down to the assignment of client executives and account representatives down to these kind of criteria. Making sure that we're putting the right people in the right place for their success, as well as the folks on the other side of the table. Okay, now let's breeze through lessons learned from the field. My career started in 1983 in the Air Force as a command control communications and intelligence officer, specializing in nuclear warfare. So there were interesting parallels, believe it or not. Like healthcare, there are strong personalities. It's life and time critical. There's this interesting mix of subjective and objective information that you have to synthesize and make these critical decisions in very tight, compressed timeframes. What's not like healthcare was the military's insistence on more data, more intel before making high-risk decisions. I'd like to think that we were better at this in healthcare than we are. I mean, there is literally an insistence among military leadership and there is great impatience if they don't have access to the right data at the right time to make high-risk decisions. And so that military insistence on better data and better intel actually drives the technology acquisition strategy of the military, right? So the military leadership doesn't sit passively back and wait for the industry to provide this for them. The military leadership proactively procures the technology to satisfy their need for more data and more intel. And I don't see that same sense of insistence and drive from our clinicians and our administrative leadership. What I see is more passive acceptance of mediocrity when it comes to data, as if they can't do anything about it. But the reality is you can force, through free market capitalism, the progression of better data and analytics into the healthcare industry if you want to. I will also say that not like healthcare is that, frankly, digitizing aircraft, satellites, and ICBMs is easier than digitizing humans. I get it. But for the same reason that we took on the challenge of the human spaceflight program, we have to take on the digitization of the human ecosystem. By the way, these are actual photographs of the work that I did in the Air Force. There's a looking glass aircraft at the top. There's a DSP reconnaissance satellite in the middle and a Minuteman ICBM below. So that's the world of digital engineering, digital ecosystem that I grew up in. And I came with that mindset and sort of that expectation when I transitioned into healthcare. And that's essentially what I've been striving to do ever since I joined in 1995, 96. If you want some interesting reading about this general topic, Google aircraft health maintenance systems and prognostic and health maintenance in the aircraft industry. There's a lot of great articles out there, and you can actually see how in the 1990s, the aircraft industry and airline industry made a very purposeful decision to become more data-driven and more digital. And so today's Boeing 777 has 11,600 reportable faults, 270 prognostic alerts. They collect more than a terabyte of data per flight. And all of that feeds into an aircraft health maintenance system. Think of that as the electronic health record for the aircraft. And by the way, there's a level of analytics on top of it and decision support called prognostics and health maintenance. Ironically, same three-letter acronym as population health management. So the concepts apply. Now we need to think about the digitization of healthcare more like engineers and less like clinicians at the moment, right? There are some pilots involved in these aircraft health maintenance systems, but for the most part, it's the engineers who are trying to maintain optimum health of the aircraft and optimum length of life. It's the same exact thing that we're trying to do with patients. Quality of life and length of life. That's exactly what they're trying to do with an aircraft. So we need to start hiring more physicists, more aeronautical engineers, more electrical engineers, and bring that influence and that mentality into healthcare. I'm going to make kind of a tangential suggestion here, back to my Air Force days. The Air Force was suffering a lot of failed contracts a couple of decades ago. And so they stepped back and said, look, our traditional approach to contracting and treaty negotiations is not working. So they funded some research at the University of Tennessee, and the University of Tennessee created a framework called vested contracting and negotiations. It focuses on outcomes, not transactions, focuses on the what, not the how. Pricing models that are incentivized to optimize both parties. Insight and resolution of issues versus oversight governance structures, focuses on open book financial discussions. I've tried several times, and when I was a CIO in healthcare, I could actually invoke these kinds of contracting requirements because I had the autonomy to do that. And it's effective. I would highly suggest that all of you think about embracing vested contracting and negotiations, including the way we contract with physicians. I think our physician contracting is a vestige of a bygone era, dominated more by lawyers. And I think we need to be more humane than we have been. And ironically, this is coming from the military. It's a common sense approach to contracting and negotiating. Okay, lessons learned at Intermountain. It was very interesting, right? I had no clue when I joined Intermountain of what an IDN was. So it was slow for me to realize that this economic balance between hospitals, clinics, and insurance was a very healthy tension. A single CEO managing the economic motives of all three of those missions balances very effectively care, quality at the lowest cost possible. That economic balance actually makes it easier culturally to achieve behavioral change because the economic incentives of everybody are kind of lined up. More importantly, that gets overlooked, I think, sometimes, is that the Utah state symbol is the beehive, and it's not about honey. It's about working together selflessly for the common good. It's an embedded part of Utah's culture. The Intermountains culture is very communal. And reducing clinical variation fit that culture. Everyone would line up around the philosophies of Brent James and David Burton to reduce clinical variation. But outside of IDN's or outside of Intermountain's culture and outside of Intermountain's economic model, it's really hard to find sticky, long-term commitment to clinical variation reduction. I just got back from a conference, international conference in Canada, and I can't remember, I think it was either 8 or 12 different countries were represented. And every single country is struggling with the same thing. That is the adherence to what we call evidence-based care. Well, what I would suggest is, based on what I just discussed about the poor state of data and research, we don't really know what evidence-based care is. And so if we really don't have a substantial understanding of evidence-based care, we don't have mathematical models, we don't have data to inform that, you can't expect physicians to line up behind evidence-based care that they feel instinctively violates what they see day in and day out. So there again, you have to address the human side of this within the context of the data that we have access to. Lessons learned at Northwestern. My first executive level meeting was a disaster. So Northwestern recruited me to build a data warehouse. They created a CIO position for me. What they really wanted was analytics and a data warehouse. So I went into my first meeting all full of myself, I'm the big new hero on the campus. First meeting with the Dean's Council. And I came in with an Intermountain-centric message for analytics, and it didn't fly. It was a Hindenburg. Dr. Drew Landsberg, the dean, pulled me aside afterwards. He's a great guy, very, very humane, soft-hearted, but very direct leader. And he said, you got to understand, Dale, you just told those physician researchers that they should reduce their variation care, but they came here to experiment with controlled variation. You better come back with a different message. So it was like a lightning bolt realization. I mean, literally, he didn't have to explain it to me. In that conversation, I realized exactly what he was saying. So the team, me, Eric Just, Mike Doyle, and others that worked together there, we pivoted our strategy towards research and addressing the needs and the motives of the research side of Northwestern. And we became data heroes. It was one of the most satisfying periods in my life and career. The other thing that I learned at Northwestern was that you can make the best out of data with good process. Just a framework that everyone should think about in analytics is the pico framework, right? Asking the right questions. The patient, how would you describe a similar group of patients to the one you're interacting with? That's a patient cohort. What are the interventions that you're considering, and how are you going to measure those interventions? Do you have the data to measure the interventions? And what do you want to do to this patient and this group of patients, then who are you going to compare the intervention to see if it's effective or not? This is kind of experimental design, but it doesn't have to be that formal. It can just be a thinking and framework thought process. And then finally, how are you going to measure the outcomes? So as analysts, this has nothing to do with SQL logic, really. This has everything to do with asking the right questions of the humans in the room, the patients and the clinicians, and then building your analytics and data strategy around it. And just following this framework will help make the most out of the poor data quality that we have while we improve the quality of the data over time. I want to call out an interesting thing that happened to us at Northwestern. So when I landed there, both the Cerner and Epic systems were pretty poorly underutilized. This was in 2005. And so we scratched our heads and we said, wow, we spent a lot of money on this. It's not being utilized. I think we better publish some core principles of clinical documentation. And we purposely constrained it to one page. We didn't make measurement the core message. What we did was make common sense the core message. So if you look at, that's the actual document on the right-hand side. If you look at that, it's not loaded with measures, it's loaded with common sense that almost anyone can agree to. Oddly, I had a conversation in 2007 with folks that would later play a large part in ONC and the development of meaningful use. They saw what we were doing. By the time I talked to them, by the way, we had built a dashboard. We were giving feedback, nudging type feedbacks to the clinicians about their use of Epic and Cerner. We weren't shoving anything down their throats. We were just letting them know this is how you're using the product that you paid for relative to your peers and relative to what we think are good benchmarks. You do what you want to with it, giving them the sense of autonomy to adjust on their own. So we had a dashboard, we had this document. This actually became the seeds of what ended up becoming the weeds of meaningful use. And I am struck by the way history twisted that the wrong way. So starting in 2009, I would say that meaningful use became meaningless use. And that's when physician burnout started to emerge and has peaked, as we've adopted EHRs and continued to roll out the concepts of meaningful use, even if we call it something else. It drained the analytic energy out of the industry. And we are obligated, friends, as taxpayers, patients, members of the community, to unwind the legacy of meaningful use as quickly as we created it and start over. It's not just for patient care, it's for the efficiency of the industry, it's for the benefit of clinicians who are burdened and burning out as a consequence. Okay, lessons learned in the Cayman Islands. That was an interesting experience for me. I loved it. I'm endlessly grateful for going there. It was a population health laboratory in a very heavily learning environment for me. And at the end, I had to nudge, not push, to embrace analytics in the Cayman Islands. And there were some interesting reasons behind that. Not the least of which was the autonomy of government-employed physicians in a small labor pool made behavioral change quite difficult, right? We couldn't go out and hire new folks that weren't willing to collaborate. And if they weren't willing to collaborate, there wasn't a lot we could do from a human resources perspective. So it tested our diplomatic skills to their fullest. The culture was also caught between the US and UK influences of healthcare, which made analytics kind of confusing. Which analytic strategies do we follow? For the most part, we built our own. And I want to emphasize that culturally, I've never been treated better than I was treated in the Cayman Islands. I love the people. I still have a fond desire to go back there sometime. There was always this sense, though, and I think there's truth to it, and it's okay, that I was the American guy with my own agenda, and I'd only be around for a short time. All we had to do is kind of wait the guy out, that being me. And that's a normal human reaction to an outsider. I have no problem with that being the case nor observing it. At Health Catalyst, I've observed a lot of interesting things across dozens and dozens of clients in the industry. And here's my observation, depicted in the cartoon on the left, the head scratcher. At Intermountain, our skills, were developed and rooted there, but they play well in some places, but not in others. I mentioned earlier that culturally, Intermountain's pretty unique. Economically, there aren't very many IDNs. There aren't very many beehive cultures like Intermountain. And so the clinical variation reduction message that we have strongly advocated has taken a bit of a back seat in the industry to an emphasis on the quality of care analytics tied to reimbursements and preventive care. Essentially, a lot of the MIPS, MACRA, meaningful use, et cetera, all of those different incentives now that are tied to quality analytics. I'm not sure if it's good or bad, but that's just reality. So we've had to adjust the way we engage with our clients so that we don't assume that their culture and their economic models can accommodate the head-scratching cartoon on the left of the diagram there. So my advice to analytics practitioners is that you have to adjust your analytics strategy to the cultural economic drivers of the client. And each of those market segments, each of those client segments has slightly different behavioral economic drivers. I'm not going to go through all these details. The slides will be available for reference. But a quick scan of that will show you that, that an IDN has different economic drivers than a large physician practice or a direct-to-employer healthcare. Certainly an academic medical center has different motives economically and culturally than a community hospital. You have to adjust your analytic strategy to line up with the economic and cultural drivers of the organization. Okay, wrapping up. Find your data empathy, especially for physicians right now. They need us and we need them. So find your data empathy. Engage with them in a way that progresses the industry rather than pulling it back, which I'm afraid for the most part we're doing right now. Be truthful and acknowledge the limitations of our existing data and analytics, then just adjust our decisions accordingly. I'm not saying that we should grind to a halt. I'm just saying that we should use our data within the context of its quality and thoroughness, and then adjust our decisions and the way we communicate degrees of uncertainty to one another and to patients. Give physicians some form of analytic hope. Give them some data that they want and need. Find it. If you don't have it, build a strategy for it, but give physicians some form of analytic and data hope. Look for and adapt to the social norms of the tribe that you're involved with, that you're dealing with, and avoid those head-on collisions. Don't tread on the tribe if you're trying to affect change. Nudge, don't push. Connect, don't convince. And let's all campaign for digitizing the patient. Rather than going to the moon, rather than going to Mars, let's digitize humanity and let's realize the full potential of the human species that will then enable us to go to other planets. All right. Thank you. All done.
Great.
Thanks, Ren. Let's see. We've got a couple other slides, don't we?
Yep, we have just a couple of wrap-up poll questions here before we jump into that Q&A. Do you have availability to stay over?
I can stay over, yes.
Okay, great. Okay, so before we move into the Q&A, we have a few giveaways for complimentary healthcare analytics summit registrations. This is an annual event with more than 1,000 provider and payer attendees occurring this year, September 10th to 12th in Salt Lake City, Utah. And the event will feature brilliant keynote speakers from the healthcare industry and beyond. This slide gives you a glimpse at some of the folks that are confirmed for this year's event. So let me go ahead and launch our first poll question here, which is, if you know that you're able to attend and are interested in being considered for complimentary passes for a team of 3 to attend the Healthcare Analytics Summit, please answer this poll question. I'll give you just a few moments there to get your votes in because we are nearing the top of the hour. Okay, I'm going to go ahead and close that. 1, 2, 3. You're going to have to act fast on these. Okay, and then one more giveaway here. If you know that you're able to attend and are interested in being considered for a complimentary individual pass to attend the Healthcare Analytics Summit, please answer this poll question. And again, you will have access to today's slides after the fact. I know Dale gave a ton of great reading recommendations, so you will be able to follow up on all of those after the fact, and we will also be posting a recording of this session. Okay, I'm going to go ahead and close that poll and then move on to our final question, which we will leave this open as we go into the Q&A. While today's webinar was focused on the importance of utilizing those right brain skills in the left brain world of healthcare analytics, some of you may want to know more about Health Catalyst products or professional services. If you would like to learn more, please answer this poll question. I'm going to go ahead and leave that open, and then Dale, I'll pull up the questions here for you. And a lot of these are really detailed, so.
Okay, great.
And you're welcome to click through on my computer too if that's helpful to you. But
all right, I might ask you to do it. Well, yeah, maybe I'll do it on yours, friend. Okay,
yeah, here,
let's see here. Let me go through these, try to triage these a little bit.
You can use the mouse right here.
Oh, thank you.
A little easier for you.
Let's see, let's read this one here. My sales experience in startups with a clinical research organization automation software for phase 1. So what drives humans to do something mostly is what's in it for me, or how does it relieve my pain, right? The only way to get to that point is for a human to allow to be vulnerable and share their pain, or the gain outweighs the risks. I see this as people willing to provide information into an exchange, or allow data to be seen shared from a policy perspective, or patient not knowing how it benefits them. So many sinks of data, but how to make people allow to trust and want to connect and share. If the motivation is enough, then it would supersede the need to control. Yeah, that's a deep thought, Suzanne. I agree, friend. I don't know really how to respond to that other than I agree with it. I think it's very thoughtful and eloquent. There's a question here. Isn't this a condemnation of the STEM movement? Well, I didn't mean for that to be the case. I referenced a lot of engineers and physicists. I've been in healthcare and health informatics for 25 years, but my undergraduate is in history and political science. The humanities students have always known this. It's the engineers and MBAs are those who don't. Well, I think there is some truth to that, David. I mean, I grew up, my undergrad is in chemistry, biology, double degree, but I went to a liberal arts school, and philosophy minor was part of what I did. I took art, and it's been invaluable to me. And I think if I've had any success in life, it's because I have had the ability to touch that right part of my brain. So I'm actually saying what I think we need to do is bring more soft skills into the engineering world, into the left brain world, is kind of the whole point of the webinar today. Again, if you go back to that diagram of mathematical maturity models, some of my clinical friends will be irritated by this, but you don't have to have great math skills to become a physician or a clinician. So the appreciation for, you have to have good stats, I would say, statistics, but not so much the kind of algorithms and math you get exposed to in chemistry, physics, and the engineering disciplines. I think we need more of that. Okay. How do you see pharmacy play in this realm of right and left brain, as we have prescription data, yet pharmacists can also play? Oh, it's gigantic. I mean, pharmacists should be empowered to do a lot more to aid and advise patients, submit orders, refill prescriptions. I mean, almost every country, I would say, I'm thinking now the Commonwealth countries in particular, but even beyond the Commonwealth, allow pharmacists to practice a lot more at a higher level than what we do in the U.S. So we need to let go of the patriarchal approach and, that kind of puts physicians at the center of every single decision, and just let it go and leverage the skills and the knowledge and the human interaction that pharmacists are so good at. Yeah, totally great point, Dee. Thank you. When our data conflicts with the subjective qualitative information we receive, sometimes we are measuring invalid and unreliable metrics. marrying quantitative and qualitative data, even in patients' family clinician narratives. This links emotion to data. Interesting point. Data that is not believed may be due to the presence of conflicting experience, subjective incoming data. That said, much of this is well stated in Novel in Healthcare. Associate Russell Ackoff's DYKW pyramid, and wallowing in data level without proceeding is evident in healthcare. Wow, Rebecca, that's very thoughtful. I'd like to hear more about your thoughts in this regard. That's very thoughtful. Connect with me on LinkedIn if you don't mind, Rebecca Hancock. Let's see. A question here. What type examples of data from healthcare do you have or can you show, like from HEDIS, CarePoint, and other type of systems that have information? What does the future of data might look like? Well, I'm not quite sure, Edwin, that I fully understand your question. Sarah, can you help? Am I missing something there? I'm sorry, Edwin, I don't fully understand your question, friend.
And Edwin, if you're still on the line, you can just resubmit, rephrase it a little bit.
Yeah, that would be great.
We'll circle back to it.
Thank you. I mean, I'll answer the last part of that. What does the future of data might look like? It's going to be more generated by the patient. In fact, what we're seeing, in the old days, all of the data that we were collecting as a society, all was collected in the data center. Well, what's happening now is that 70, 80, 90% of the data that's being collected in the world is being collected at the edges of humans' experience. It's not in the data center anymore. So absolutely, biointegrated sensors and patient-generated data is the future. That's the volume of data. It's going to go up exponentially to the edges of the organization and society. Let's see. Oh, hi, John Kanegi. The evidence presented suggests the solutions to digitizing healthcare lie outside the social norms and capabilities of the current tribe of digitizers. Let me think about that. Is it outside the current tribe of digitizers? I'm not so sure, John, because I think ultimately we all belong to the patient tribe. I mean, I think that's one thing that we can all rally behind. Now, that may, quite often physicians don't see themselves as patients, but their families certainly are. And I think the tribe that will drive digitization has to be two tribes. It has to be patients who insist on better care. And then going back to the military analogy, it has to be the leadership in healthcare that demands and insists on better intelligence data to support their mission. That's the thing that the military leadership does very well. They insist on better data and they procure and they drive the development of technology that leads to better decisions. Whereas in healthcare, physicians and administrators sit sort of passively back and buy mediocre products, spend billions of dollars on those, and they don't insist on something better. Gigantic misstep in our country's evolution of healthcare when we incentivized all of that money from high tech on existing products that didn't progress the digitization of the patient in any substantial form. Okay, let's see here. Lawrence Epstein asks, would not banding the patient by segmentation of expected need have more success than digitize individuals? Well, I would say, Lawrence, that we can't accurately band patients by expected need if we don't have more data about them. It's a smeary image. It goes back to that highly pixelated image of me and my family. And we can take and we can make an attempt at segmentation based on the data we have, but the segmentations are not very precise, right? I kind of live in this world for years. The patient types and patient segmentation that we have is pretty imprecise. It's grossly imprecise, actually. But we do have some hope ahead, though. AI, machine learning, pattern recognition algorithms are allowing us to see patterns in data and segmentation of patients that we've never been able to see before. And you'll see more of that emerging in the industry, and you'll see more of that emerging from Health Catalyst specifically. Let's see. Vamsi Marla asks, you started this talk discussing data sharing between companies to deliver consistent and quality care. Did I do that? Did I start it by talking about data sharing? I'm kind of sleepy. Maybe I did. What are some incentives that can be provided to providers to share data, particularly those not in academic centers? I recently read that this is happening in the automotive companies, especially with autonomous driving tech. This is probably partly because the auto companies are now competing with tech companies for market share for cars. What are some thoughts to deliver a similar incentive to accomplish data sharing in healthcare? Oh, well, I think my short answer to this complex topic, Vamsi, is that the patient has to be at the center of the data sharing ecosystem. So right now, there's literally no incentive whatsoever for healthcare providers, insurance companies, et cetera, to share data with one another. In fact, there's disincentives economically. So what I hope is that over time, as the gravity of data, the center of gravity for data has to shift to the patient, and as it shifts to the patient, then my computer's about ready to restart here. Then as we shift to that gravity to the patient, then I think it's going to be up to them to decide how to share it, rather than the perverted way that we have it right now, which is healthcare systems deciding what should be shared and insurance companies and things.
We are 9 minutes past.
Are we 9 over?
Call that out, so
let me just see here. There's any. Oh, Andy Cantor. I have to. Andy, I got to get to you here, friend. You're going to put me on the spot, I'm sure. So I'll give you a chance to make me squirm here. Perhaps from Andy Cantor. Perhaps the question about the form of the data. Do we really argue about the quality or the content of a data element, or about what data element means? Well, that too, right, friend? The ability to interpret the data is as important as just recording it. We can map the genome, but what does that actually mean in terms of the patient? The interaction between genes, proteins, microbiome, behavior, everything. Can we capture data in a way that allows for capturing all those interactions to be able to transform the data based on context, et cetera? Our analytics aren't going to make sense without it. Yeah, I agree, friend. I mean, I kind of come at that from two different ways. I've never met data that I couldn't eventually make sense of. So, a lot of times going back to the military, you would bathe payloads in sensors, for example, and you didn't always know exactly what kind of insights or what you might do with the data, but boy, you sure were glad you had it when you did. And then your ability to exploit and understand the data tended to evolve after your realization of its collection. So I would not say that we have to have a firm understanding of how we might interpret the data before we engage in the collection of data. I think sometimes the understanding follows the collection. But yeah, that's always insightful there, friend. Thank you. What do you think? Maybe till 1:15?
Yeah.
3 more? Okay. I can stay for whatever. How many people do we still have on?
173.
173. Okay. Working at an IDN, my experience has shown that digitizing is only one step towards this revolution. Data sharing, yeah. We get back to it, don't we, here, Bill? Bill Hickman asking, data sharing even between silos in an IDN is lacking currently. I agree with that. How can we move that aspect forward to help analytics advance care, especially in light of the CMS future push towards population health management? Well, there is absolutely nothing within the scope of data sharing at an IDN that prevents a CEO of that IDN to force data sharing if it's not happening. And it's a shame that it doesn't. I worked on a giant, very exciting, very interesting project in Alberta a few years ago. It's still kind of going on. And it was fundamentally about creating a data resource for Alberta as a province to inform precision health and population health. And we brought together, I think we had 9 focus groups, 85 some participants on those focus groups. And it was all about data sharing. and crossing those human barriers, again back to the soft skills. And most of the time that I spent in that endeavor was motivating people, getting people to believe in a purpose greater than themselves, getting them to believe that that sharing data is as important as sharing organs and blood. And here's the interesting thing too. We had a large constituency of patients informing us. They were one of the most prominent. In fact, they co-led the project, our patient advocacy group, and they were stunned. The patients on that panel were stunned that we in healthcare in the U.S. and in Canada were not sharing their data more effectively for the betterment of their healthcare and their lower costs. They were stunned to find out that we weren't already doing this. So all of this hesitancy that we have around privacy and all that kind of thing is, to me, it doesn't hold up, because patients expect that we should be leveraging this data to their benefit already. And of course, protecting its privacy, which we can do. So just keep pushing, Bill. It should go all the way up to your CEO. Let's see here. There's a question from, as Chief Clinical Officer at a behavioral health system, I'm trying to mobilize the culture to use clinical decision support. My strategy is to use a small number of metrics and use the data to tell a relevant story to our clinicians about what they do and the results of their efforts. Any thoughts on how to nudge a culture that is self-proclaimed data averse? Well, I would say, first of all, friend, behavioral health, going back to my, progression of mathematical maturity, it's over on the far left. If you really kind of talking about psychology and psychiatry. So decision support in your environment is probably the most complicated that we have in healthcare. So God bless you for taking it on. The way that I approach decision support at the clinical level embedded in the EHR is I actually look at it in 3 loops of decision support and the analytics associated with that. So you want to make decisions, clinical decisions at the population level, hundreds of thousands of patients affected by the decisions and the analytics at that level. Community health, population health is kind of the theme. The next level down, then the next loop is the protocol level. So now you're segmenting the population and you're saying, in general, we want to treat patients of this segmentation this way, generally speaking. That's kind of where evidence-based care comes in, protocols and that kind of thing. So populations at the top, protocols in the middle. You're dealing with tens of thousands of patients, maybe in that group. Your mean time to improvement there is measured in months and maybe hopefully even weeks if you can turn your protocols around fast enough. And then the last is the area that you're working in, which is the hardest, which is clinical decision support. And that's at the patient level. So it's populations, protocols, and patients. And that's where controlled variability and variation from the protocol is justified in the pursuit of personalized precision care for the patient. So my experience has been, if you engage with clinicians around those 3 closed loops, using the same data to inform those loops, different types of analytics, obviously, different types of algorithms. That's one way to engage clinicians in a healthy discussion. The other is I invoke a study that Ken Kawamoto at University of Utah and Intermountain LDS published in BMJ a number of years ago that showed if we give clinicians the substantiating data to change their decisions at the point of care versus a conference room somewhere, they're 15 times more likely to change that decision if you give it to them in their workflow. They're 15 times more likely to follow a best practices protocol if you share that decision support with them in their workflow. So that's the good news if you can do it. The bad news is, quite frankly, is electronic health records and their software APIs make clinical decision support very complicated to implement. Most of those user interfaces were not designed in JavaScript and HTML5 and all the tool R and Python, right? That's not native to the EHR software architectures. And quite frankly, that software architecture of EHRs holds back our ability to inject clinical decision support. So you've got a big challenge. I don't know if I helped you there, but let me know if I can help any further. Reach out to me on LinkedIn maybe. Okay, I better take one more question here, and this one is a good one. They're all good. You have not referenced AI. Does that impact analytics? Yeah, for sure, friend. So I embed AI within the broader context of analytics. So it's a form, it's a subspecialty of analytics. It has its own unique complications, but I actually believe that AI has the ability to engage better behavior, I'll say behavioral change more effectively than what I would call the rules-based declarative programming approach that we have traditionally followed in analytics. So moving from SQL to sort of the fuzzy world of AI, the pattern recognition world of AI, is actually more in line with human cognition than the left brain rules-based approach that we followed in healthcare analytics up to this point. So AI has the potential to push us further along with behavioral change, even though there's a lot of debate right now about, the validity of the models and the training and the testability. We're going to get past all that. And eventually the output of those AI models is going to resonate with the human brain better than the rules-based approach that we followed so far. Okay. Well, I don't think I can talk anymore. There's one more.
You did have a note from a friend on the
A
line.
tool. Well, thank you, Atul. Good to hear appreciate you joining, friend. It would be really boring if no one joined or asked any questions, so thank you. The audience makes the show, not me.
All right, ready to call it?
Yep. Thanks, everyone. Have a great day.
All right, we want to thank Dale for taking the time to present to us today. Thank you, Dale. Fantastic. I know you were a little tired coming in this morning, and you did a fantastic job. We also want to thank everyone on the line and everyone who's already left us for joining today. Please do us a favor and complete the short survey as you exit today's presentation. Your answers will help us to deliver more valuable content in the future. As a reminder, by midday tomorrow, you will receive an email with links to the on-demand recording, the presentation slides, and a transcription. We'd also like to invite you to join us for our next webinar, Population Stratification Made Easy, Quick, and Transparent for Anyone, which will be held on Wednesday, July 31st. This presentation will feature Health Catalyst's SVP of Application Suites, Eric Just, who will delve into the challenges inherent in population stratification and share tips for easing that burden and streamlining processes. We hope that you will join us for that. On behalf of Dale and all of us here at Health Catalyst, thank you for joining us today. This webinar is now concluded.